as Tom said, we like to make this diagnosis. I always kind of paraphrase the old why world of sports, the thrill of victory and the agony of defeat, because a year later, you're dealing with resistance, and you're dealing with several flavors of progressive disease. Ben, walk us through the kind of thought process about mechanisms of resistance and what we should be thinking and doing.
Sure, yeah, I think that we've got similar to how we understand up front genomic characterization of lung adenocarcinomas for initial treatment decisions, we've got a better understanding of mechanisms of resistance for those patients treated with EGFR-directed therapies. I think we know now that probably 50 to 60% of patients develop a second site EGFR mutation in T790M. We've got other mutations that have been elucidated, PI3 kinase mutations, MET amplification, and then reported small cell transformation. So I think with this better understanding becomes more of a direction that we need to understand what's going on at progression with either a tissue biopsy or even plasma genotyping, bringing this back into the fold. Interestingly, the T790M directed therapy, osimertinib, in their EAP did allow T790M to be captured from the plasma to drive the enrollment. So we've got the onus is now to really understand this either with tissue biopsy or plasma genotyping. I would argue that still the gold standard is tissue biopsy to understand what's going on with these patients, because we have now available therapies in clinical trials that are targeting these mechanisms of resistance.
So this is a huge paradigm shift for us, because we never rebiopsy, right? We were always happy with the first biopsy, but I think we have to rebiopsy. Yeah. I mean, blood is coming, and we all use that, but I believe tissue and blood are complementary. You may not get the answer on blood, so tissue is part of that. And I would argue, I mean, we have several patients where they've had 3, 4, 5 biopsies over time, because we know T790M can change over time in this particular setting. So we, as of 3, 4 months ago, now have a drug for this setting. Walk us through that data with osimertinib.
Yeah, so there was data that was recently published just in April 2015 in New England Journal of Medicine, looking at osimertinib, which is a T790M directed therapy, third generation TKI. Patients had received first generation TKI and had developed a T790M, documented T790M mutation. And with delivery of this drug, the response rate was in the 60% range, which if we put that in context of what chemotherapy does in this setting, it doubles it basically. I think we know chemotherapy in this setting elicits a response rate of around 25 to 30%. The PFS was around 9 to 10 months, I believe, which again doubles what the PFS historically in chemotherapy, and very long durations of response. For those patients that did achieve a response, the duration of response was more than a year. So just as important, I think, as the efficacy is the tolerability of this drug. Very manageable AEs, and because it spares wild-type EGFR, we're not getting the rash and the diarrhea that we've seen with these first-generation TKIs. And unlike the other third-generation TKI, ruxolitinib, there's very low risk of hyperglycemia. So overall, I think completely changed the landscape of what we're doing in this patient population, completely changed what we need to do with biopsying these patients to identify T790M, but really a win for the patient because of the efficacy and tolerability as well.
What's your experience been, Tom?
They're very well tolerated, and we've had a number of these third generations, and they're, I think, a huge advance, like Ben said, about the not much rash or diarrhea, the stereotypical EGFR toxicities. And the patients tolerate them very well in terms of fatigue and other toxicities, and it's a paradigm shifter. There's no other way to put it, I think, at this point.
And Jared, what's the message for the community oncologist in this situation? Is it think about rebiopsy, think about retesting in this population?
Oh, I think it's a simple message and even stronger than that. I think at progression, every patient with EGFR mutation who's progressed on one of these first-gen TKIs should have a repeat biopsy to ascertain the mechanism of resistance.
Let me explore that a little bit more, because we know that many of these patients with EGFR mutations, even though they may meet RECIST criteria, they have very slow progression. Mm-hmm. They remain asymptomatic. The 7-millimeter nodules go to 9 millimeters, and the report says progression of disease, patient is fine, patient's perfectly happy on erlotinib. Yeah. When do you biopsy?
So I think you biopsy when you're going to use it.
When it's time to say uncle.
I think that's right. In clinical practice, there's certainly, this underscores the importance of looking at your own scans, right? To understand not just progression, but is anything rapidly progressing? Is anything progressing near a central airway or vessel that scares you? Is the patient symptomatic from the progression in a way that can be explained by scans? And there are, two alternative options to switching agents. You can just put a thumb over whatever's bothering you if you think it's not threatening your patient, or if you think it is, but it's an isolated site that's easily accessible to some form of ablative or resective surgery, you can destroy or remove that spot. We have a trial ongoing doing so with stereotactic radiosurgery.
Yeah. I always like to think, as I look at multiple scans over time, if I do nothing, what's the patient going to be like in 3 months? Am I putting that patient at risk of either more rapid progression or some visceral crisis or whatever that it may be? And if I'm nervous about that, it's time to make a switch, but you got to rebiopsy first. So, Greg, let me